Great. Thank you for the opportunity to present. My name is Dan Gage. I'm a third-year general surgery resident at The Ohio State University. Today I'll be talking about the establishment of a 24/7 acute care surgery robotic surgery program at our large academic medical center. The authors have nothing to disclose. For some background information, there are 5 million minimally invasive surgeries performed in the United States yearly. Robotic surgery represents an increasingly large proportion of these operations, representing an 8-fold increase in the amount of cases that have been completed from 2012 to 2018. There's been numerous benefits to this modality, as well as comparable outcomes across multiple studies that have been published in multiple general and colorectal surgical procedures. Additionally, there's the training benefit to this modality, as there's been noted to be a shorter learning curve for trainees, and along with better ergonomics for the surgeon. Some background information about our institution. We're a large academic medical center that covers trauma, emergency surgery, and surgical critical care. We're also a level 1 trauma center with over 3,500 patient encounters per year. We're a quaternary care referral center with a large catchment area, and we perform over 2,000 emergency general surgery cases per year. As part of our practice, we also cover a level 3 center for trauma and emergency general surgery at a community hospital in the city of Columbus. As I said, we're a large center. On our main campus, we contain 1,404 beds. In the division of trauma, critical care, and burns, there are 15 faculty members, 6 of which are now trained to complete robotic surgery cases independently. Additionally, we have 2 trauma surgery fellows who are able to complete their certification and complete those procedures independently as well. Across our institution and multiple subspecialties, we completed over 3,485 robotics cases in the year 2023. I guess this all next begs the question, why should an acute care surgeon care about robotic surgery? Intraoperative consults in our specialty are common. We're often asked to participate in complex procedures with our subspecialists, and the ability to take over the robotic console and continue the case via that modality is crucial, as many of these patients present with surgical problems or comorbidities that would make other modalities more risky and higher risk of morbidity. Additionally, our own patients would benefit from minimally invasive surgical approaches to their care. So with this in mind, we set out to create our own robotic surgery program in the Division of Acute Care Surgery. This is how we started our program. We first identified our stakeholders. So the first step was identifying faculty members who would be able to complete the cases independently. We then worked along with our operating room leadership, who was responsible for scheduling these cases and organizing our personnel. And then we worked to organize both our circulating nurses, our surgical technologists, as well as our central sterile supply to help support these efforts. Our initial workshop model, where we got a group together to discuss what immediate concerns would be, did reveal some large questions we would need to answer. How do we generalize our instruments for our acute care surgery cases? What physical operating rooms would we use to complete these operations? How would we get the equipment to where it needs to be? And how do we train our staff so that they can all participate in these operations on a more acute basis? To address the first question, how do we standardize our instruments? These are provided by our central sterile surgical supply, and we generated a protocol that would allow for the completion of 2 add-on cases per day. Listed below are the universal instruments that are included in all of our sets for our procedures. When a patient is scheduled for an add-on cholecystectomy, we also included 2 large clip appliers in that set. For our additional considerations, we had to identify specific operating rooms. During the daytime hours, the robots are in various locations and can be wheeled to different settings. Our acute care surgeons identified 4 operating rooms that we thought would be appropriate for use of the robots in this setting per day. In terms of equipment, we worked with our central sterile supply to deliver the instruments when we would call for the case, and then our staff that was in the operating room setting would be able to assist with transport of the robot if it needed to be moved to another room. Although most of our cases would be added on after the completion of the elective cases that day. We then worked towards our training process for our employees. So this was an integral in part of the establishment of the program. Our registered nurse first assists, which are generally available for our elective cases, are not generally available after business hours or on weekends. Therefore, we needed to work with our operating room staff to complete additional trainings to help with bedside assist and circulate within their scope of practice. We started with a 3-month trial period with faculty or staff members who were particularly interested in helping with this effort, and those efforts have since been generalized so that the entire operating room staff at our institution has completed the training to be able to participate. In terms of faculty, there were a few interested faculty who started the process, and they worked as in a mentorship model with our Division of Gastrointestinal Surgery department on a more elective basis to help get their certification to complete their cases independently. We then worked on a pay-it-forward model with these acute care surgeons who would be able to provide supervision to their colleagues in the department to complete 5 cases as an apprentice before they would be able to complete procedures independently. Additionally, our fellows complete dedicated cases during their fellowship training that also allow them to gain that certification. This is a summary of our current process for scheduling a case. When a patient comes in with an acute surgical problem, we identify that on our team, and then we identify a surgeon who's available to participate or complete the procedure. We call our OR front desk and ask for the availability of the robot at that time. If not, we would proceed with our more traditional modalities, being open or laparoscopic approaches to these problems. But if it was available, we would be able to identify an operating room that was capable that we could schedule that case, speak with our central surgical supply to get our pre-made carts up to the appropriate room, and then we'd be able to proceed with our case in a standard fashion. The protocol as it currently exists allows for us to call at any time of the day to inquire about the availability, and this is especially helpful during the nighttime hours. This is a representation of our case volume over time. Our program was started in 2022 in the first quarter of the calendar year and has shown a steady uptick in the number of cases that we've been able to complete. Up to concluding quarter 4, we completed 50 cases robotically. This represents over a 200% increase over 1 year, and we continue to increase our productivity as the modalities are available. Just a summary on some of the lessons we've learned so far and some of the additional questions that came up. We work with our operating room staff on each day so that the front desk can identify both a surgeon, if they're the acute care surgeon who will be on call that evening, if they have availability and are able to complete a robotics case. And then the OR staff each day operates or identifies a room that would be added on for robotic cases if applicable overnight. We had to change our stocking schedule. Central Sterile Supply would typically create robotic cases sets in line with an elective case schedule, but we needed to talk with them about establishing a more frequent stocking of that equipment so that it would be available at all times. Not all rooms are equal, and we had to work on finding cases that robotics would be best suitable. And then we had to work on the availability of bedside assistance and instrument handling, with the residents always being available to bedside assist if necessary. We routinely perform case reviews of on-call cases that have been completed to make sure we're appropriately using the tool. And with that, I'll take any questions.